All right, good afternoon, everyone, and welcome to our February Teach Educational Rounds, which is a Cessation in Black Communities panel discussion. And here with us today, we have Dr. Onye Nnorom, Brenda Osei-Boadi, and Jama Yusuf, who will be talking about this. So to get things started, I'm going to share our CAMH land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. And today, Toronto is covered by the Toronto Purchase Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis and share the land and protect it for future generations. And so now this is the time where everyone, you're welcome to introduce yourselves in the chat and also to share which land you're joining us from today. I'm going to share a link that you can use to find out if you're not sure. And you're also welcome to share something you're currently doing to improve your commitment to reconciliation. And in the meantime, I'll share my own brief land acknowledgement. My name is Rachel. I am a second-generation Canadian located on the Mississaugas of the Credit, which is covered by Toronto Purchase Treaty Number 13. And I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard. So I'm going to keep going with some announcements, but you're welcome to introduce yourselves in the chat while this is going. We'd love to hear about you and where you're joining us from. And so a reminder that if you did want to receive a letter of completion for this Teach Educational Rounds, to make sure that you registered for the webinar and completed the full pre-learning assessment. Also to sign into the webinar using your first name and your last name, because that's how we'll identify you to give you your letter. And also to complete the evaluation and post-learning assessment. And both of those will be sent out to you after the end of the webinar. And so as a bit about our presenters today, first we have Brenda, and Brenda is a counselor therapist at our Intrepid Lab here at CAMH, and she specializes in youth fast. She supports youth ages 12 to 21 facing challenges with vaping, substance use, and technology dependence, focusing on mental health, addictions, and culturally responsive care for young people and their families. Our second presenter is Jama, and Jama is a research coordinator also at our Intrepid Lab here at CAMH, where he primarily works on the CCF project, which is about improving cessation outcomes within Black communities. And we also have Onye. Dr. Nnorom is a distinguished physician, advocate, and public speaker and leader in the field of public health and equity. She is a family doctor and public health preventative medicine specialist. She is Associate Chief Medical Officer and Health for the province of Ontario and the Chief and Medical Director of Health Equity and Population Health at Lakeridge Health, and the Black Health Faculty Lead in the Department of Family and Community Medicine at U of T. She is also a medical consultant at CAMH. Dr. Nnorom has dedicated her career to addressing health disparities and improving health outcomes for marginalized communities, with a particular focus on Black populations. Dr. Nnorom is the co-founder of the Black Health Education Collaborative, which is established to provide online educational resources on anti-Black racism and Black health for health professional students, clinicians, and public health practitioners. Recently, she launched a social media outreach initiative called Healthcaring Differently to encourage diverse youth to explore careers in medicine. Dr. Nnorom's expertise lies at the intersection of anti-racism, community health, and healthcare transformation. So I'll give everyone a moment to read through our presenters' disclosures. starting with Onye, Dr. Nnorom.
Yeah, so for financial relationships, certainly, you mentioned the Black Health Education Collaborative. So, not presently, but in the past, I'm connected with them. But aside from that, specific to today's event, I don't have any other conflicts to declare.
Perfect. And as well as Brenda's, which are on the screen, and Jama's as well. And this is a note that all eligible Teach Educational Rounds presenters are offered an honorarium for their presentation, but acceptance of this honorarium does not impact presentation content. We'd also like to note that the content of Teach Educational Rounds are centered around the following guidelines. And these materials, as well as their verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. And with that, we can get started with our presentation. So Dr. Onye, I think Dr. Nnorom will get started.
Yes, so thank you for having me. I am a physician here at CAMH, and I work at the Nicotine Dependence Clinic. But I'm speaking mainly from like my outside expertise, which is around Black health work and education. So I'll be covering the first objective of how anti-Black racism and other structural determinants act as chronic stressors contributing to smoking behaviors and health disparities among Black communities. And then my colleagues will get into identifying the key cultural and mental health factors and describing the culturally responsive models for smoking cessation. So I'm objective number 1. So let's jump into it then. So for me, before I begin, certainly I just want to remind us that we are in the second International Decade for People of African Descent. So we remember our ancestors. It's a period for recognition, justice, and development as recognized by the United Nations. And you can see the dates in there for the first decade for people of African descent. Quite a bit of that got consumed by the pandemic. So we are now in the second decade, and we appreciate that. And it's a time for really understanding African peoples and descendants of African peoples, but also how anti-Black racism impacts our everyday, which brings us to the next slide. So I'm going to be talking about how racism impacts health, and anti-Black racism is my case example. So the things that I'm going to be talking about today are not exclusive to how Black folks are treated in this context, but speak to that, or I'm speaking to that specifically as my case example, and one can kind of interpret for other groups. So I'm grounding that in this for us, and that's my area of expertise. So when we think about anti-Black racism, I just want to make sure we're all on the same page. So this is the definition that's used by the province of Ontario, as well as the African Canadian Legal Clinic, and was created by a Black female scholar, Dr. Akua Benjamin from TMU. And so we're talking about the prejudice, and discrimination. I'm not going to read every word on there. And the discrimination that is that is directed at people of African descent and rooted in our unique history and experience of enslavement. That ends up being tricky for some folks because we're a very diverse population when it comes to Black folks, and not everyone has slavery in their lineage. However, anti-Black racism is rooted in our unique history and experience of enslavement because the stereotypes about Black folks, the implicit bias that we talk about sometimes. So if you look on the right, quick, rent to one. So that was part of a campaign with the city of Toronto a few years back. The stereotypes about Black people do trace back to slavery, which we did have on this land for almost 200 years. Many Canadians were taught about the Underground Railroad, which was only for 30 years, between 1834 and 1865. when slavery was abolished in Canada and had not been abolished in the United States. But very few people have been told about those 200 years here in Canada, and also coincides with the United States, where you had stereotypes to justify slavery, that Black people were subhuman, less likely to be trusted, had a different pain threshold. And so all of those stereotypes to justify slavery matter for Black folks, whether you have come very recently to the country and slavery is not part of your lineage, or if your lineage traces back generations here in Canada. And so that is really important because it's entrenched in our Canadian institutions, policies, and practices. And the legacy of that really is within our current social, economic, and political marginalization as African Canadians. And so with that, we see that the United Nations had great concern for the well-being of African Canadians or Black people here because of this legacy in Canada of anti-Black racism. And I'm here because it's also impacting our health. So next slide. So just a couple of things before we get into how racism impacts health. The first thing that we have to unlearn, right? And I'm coming to you as a physician. We've all trained, with the thinking that race is biological. So we have to unlearn that, right? We know the human genome has been mapped. There's more differences within racial groups than between. So we have to remember that it's a socially constructed way of judging and classifying people based on phenotype, right? Like hair and hair and skin color. We're making genetic assumptions. And so that is problematic. However, we also have to remember the flip side of that race, even though it's not, we don't have biological races, the social construct is a powerful force that has real consequences for individuals, and particularly for Black people because of the anti-Black racism. And so the European concept of race arose at the time of the scientific revolution, European imperialism, and colonization. So that's what was used to justify a lot of atrocities that were done. I have that lovely picture of Trevor Noah there because in South Africa, where he is born, he would be considered colored and not Black. But in North America, in the United States or in Canada, he would be classified as Black because it's a social construct. I used to spend a lot of time explaining this because in medicine, we're taught about differences between groups and we assume it's biology. But I spend less time on that now because of slide number 2. So next slide. So it's really hard for us to unlearn as physicians, but usually if we see different groups having a different representation, it usually is geographical or ancestral. So something like sickle cell, if you say it's all people who are Black, that's actually not correct. You don't see it as often in South Africa or parts of East Africa. You largely see it in West and Central Africa. And those were the people who were predominantly brought over during the transatlantic slave trade. So we create all kinds of confounders simply to say that the American Medical Association has decried this use of race as a proxy for ancestry, genetics, or biology. So I kind of just leave it there, but there's a lot of unlearning that we have to do. Much of the differences we see are either specific to West Africa, Central Africa, or are the impacts of racism. So now we can launch into the next slide. So it matters. Like sometimes in different audiences where people are not healthcare providers, and why would I even bother giving, saying that, is it biology versus health inequities? It matters fundamentally because when we think that it is biological, then there's nothing for us to do. That's almost like it's deterministic. But if it's social, then the onus is on us as a society to make that change. So, and that's true for everybody, whether you're a healthcare provider or not, it's to understand that we need to make those societal changes for people to have better health outcomes. So what I say to folks is, you think of a condition like diabetes or high blood pressure, we hear on the radio, it is more common and presents earlier for Black people, for South Asian people, for Indigenous people. So is it that we all have the same mutation? Or are we in similar situations that are driving disease? And so that's the big unlearning that we have to do in healthcare so that we are able to better serve our clients and patients, but also that we need to do as a society so we can do better and have better health outcomes. So how does racism impact health and how does it drive health inequities? That's the next section and the biggest section of what I'll be talking about. So this slide is really to go, well, I'm going to kind of break it down into different parts, but we'll start on the left. So really it's how I talk about how we go from social influences to poor health outcomes. This is not specific to anti-Black racism. So as I said, anti-Black racism is my kind of case example. So for social influences, I highlighted history. We're in Black History Month. But, what we know and do not know about our history, for instance, what I said earlier about slavery, most of us know about the 30 years of the Underground Railroad and not 200 years of slavery, then that impacts our worldview, along with religion, art, media, culture, all of those things. And then that impacts the middle column, so racism. And I actually do not differentiate whether it's conscious or unconscious racism or bias, because I'm focused on the people who are impacted, and the impact is the same. So I don't dance in that space of debating if it is conscious or unconscious. The point is racism occurs and can happen at 3 levels. So you can click next, because I think it'll take us to underlining there we go. So we know about the individual or internalized level, and particularly we know about the interpersonal level. So the individual or internalized level is actually where somebody is part of a racialized group and believes the stereotypes about their group. It's internalized. So for instance, for a young Black child who has not seen a Black doctor, they might start to internalize or believe that maybe Black people are not smart enough to be physicians, not knowing that we were intentionally and structurally excluded from the field of medicine for a very, very long time. So that's how it can be internalized. Interpersonal is what we hear and see, a hate crime, something like that. We hear about it on TV or in the news, and can still happen in healthcare and have a major impact. So that's saying or doing something racist to another person. But at a population level, where we see the wear and tear and major health outcomes is at the systemic level. So you can click next. It's really at the systemic level, and it's understanding. We go back to the land acknowledgement that we heard this morning. It really is about the fact that on this land, it was a colonial project, and arguably still is, that positioned white Europeans as superior, not only in appearance, but beliefs, in actions, culture, behavior, everything, and positioned Indigenous people, Black people, and other folks as inferior. And so that set the standard, that set the structures that we have today. The legacy is still with us, such that really, if we're not actively anti-racist, you still see a pattern of unearned privilege and unearned disadvantage that impacts folks and leads to, on the third part, poor health outcomes. And I separated into the direct and the indirect. So we're going to spend a bit of time talking about that direct. So that's where it leads to chronic disease, mental health outcomes, and delays in access to care, but that's the stress of racism. The indirect I'll come to very briefly before I finish, and that's more other social determinants of health, so their interaction. But let's dive into the direct. Thank you. So it's thinking about racism as trauma. And so race-based stress, it's really important to understand, does not only occur in the context of that interpersonal category that I talked about in the slides. Interpersonal certainly has an impact, but at a population level for your average everyday person, it's going to come from other forms of race-based traumas, which can include witnessing ethno-violence or discrimination of another. So for instance, the murder of George Floyd, it's very uncommon to actually watch the murder of somebody on videos over and over, but the Black population has been exposed to that, almost a public lynching kind of thing that you're seeing on social media. And so for Black folks, it can have an effect of vicarious traumatization. There's an excellent article in The Lancet really looking at that, comparing different groups. But when it is an unarmed Black man, it does impact Black folks differently, because there's that understanding or feeling that could be your father, your brother, your son. And so that can have a traumatic effect. History or personal memory of racism, and that can interact with the vicarious trauma. Institutional racism, entering a workplace or a new space and realizing that folks who look like you, especially in a city like Toronto, where the Black population is 10%, are not represented with regards to the leadership or folks who hold power, or walking down the hallway and seeing nothing but the faces of older white men that are hung on the wall as far as the history of leaders, right? That can actually have an effect as well, and create stress. Not to mention microaggressions, so the everyday, indignities. So being carded, being asked constantly, where are you from, being questioned, and then the constant threat of racial discrimination. So the threat of it is different for Black folks and for racialized folks. So think about when you might have a job interview. The night before, everybody's stressed out. But for a Black person or a racialized person or a person with an accent, the night before is thinking about all the stereotypes and how to duck and dodge them so that you can be a candidate for the job. How are you going to put your hair? Can you wear it in an afro? If you have an accent, do you have to speak in a different way? Can you wear Afrocentric clothes, or are you going to be discriminated against? That's even before the thing has happened. It's the anticipatory stress that is different for racialized folks. We're going to go to the next slide. And so the bottom line is, when we think about it as trauma, it can, and you are sensitized through ongoing racism. And so that's going to be different when you're a child. Like I have 2 young boys, ages 8 and 10. So where you're experiencing racism institutionally, for instance, kindergarten teachers and other elementary school teachers, it's been shown make less contact. So just, a rub on the arm or something like that for Black children, especially Black boys, compared to white children, right? So when you're growing up in that context, routine slights can take an increasingly greater toll over time. Different if you're a new immigrant to the country. You might not notice it right away. So the sensitization matters. And so it can result in poor health behaviors and outcomes. So that can be a serious psychological distress, which is what I've seen most in clinic, PTSD, depression, anxiety, or physical health consequences like high blood pressure, like I mentioned earlier, or binge drinking or disordered eating. And sometimes that's overeating. So just going to work while Black, driving while Black, living while Black, parenting while Black means you come home exhausted. And maybe you are not going to go to the gym and jog. Maybe you're going to have a donut because it is that stressful. And so the disordered eating can present in different ways due to the distress. Next slide. And so I also just want to, I'm not going to go over this slide, but to those who are interested in how racial trauma can be understood through a PTSD lens, then I just wanted to share this excellent resource by Dr. Monica Williams from the United States, which kind of breaks down what we can understand about racial trauma or racist event, and putting it in the context of the DSM-5 for PTSD. Okay, next slide. And so before I wrap up, I just want to kind of talk about the indirect impacts of racism. So before that, I was talking about, when you know that racism is occurring and the stress that happens with that, whether it's chronic disease, mental health, or just delaying going to see a physician. But for some folks, you might speak to Black folks, racialized folks who will say, and it shows in surveys, that they've never experienced racism. Often they're thinking about interpersonal racism, where somebody has said something racist or done something racist. But what we know is that poverty is racialized. People have loss of opportunities. And so, what I've seen is, systemic racism is an academic term, but even if you don't know what systemic racism is, if you are Black or racialized or Indigenous on this land, then odds are physiologically systemic racism knows you. It knows you through that working twice as hard effect, or I would say 10 times as hard in certain situations. So go to the next slide. So this is an example of racism throughout the life course, but just explaining that, whether it's early child development of Black children being more likely to be investigated by child welfare services and removed from their homes, and that is second to Indigenous communities. So whether it's the threat of that or the experience of that, whether we're talking about in education, Black children being more likely to drop out from high school. And we know that from work done in Peel, it's from the experience of hypervisibility when they do something wrong and being over penalized, and invisibility when they are doing very well and they don't get the same mentorship or not considered as excellent. So it's those slights, the social environment. So we know that Black people are overrepresented in our correctional institutions, whether it's in employment. We know that a Black person with a graduate degree, at least for Montreal, between 1996 and 2006, that's where that data is taken from. But a Black person with a graduate degree had the same unemployment rate as a non Black person, so a white person who had dropped out of high school, right? So that idea that education guarantees that, upward mobility does not often apply to Black people in the same way. And of course, a Black person earning less for what a non-racialized or white person earns. So simply to say that across the life course, it will take a toll as well, even if you're not conscious of the racism that is happening. Next slide. Okay, and I'm going to wrap up because I think the team said I have 15 minutes. I think I've exceeded that at this point. So I'm going to be quick in saying I'm just going to wrap up and bring it back to a broader piece and then to smoking. So for the United Nations Working Group, as I mentioned, for people of African descent, when they visited here, they said specifically for Canada, several factors contribute to the health disparities, including historic barriers to access and continuity of care, long-standing systemic racism, low socioeconomic status, lack of cultural specificity in health education, and underrepresentation of Black health professionals in the system. So it's multifactorial, but again, things that we can collectively do to address these barriers. And so bringing it back to smoking, and I will hand the virtual microphone over to Jama, my colleague, in a moment. We'll just go to the next slide. And so unfortunately, my graph did not show here, but it is okay. So just imagine a colorful graph on the left, but simply to say that we know from the United States and from Canada that, Black populations and white populations have different smoking rates. In the United States, it's slightly less than the white population. I don't even know if it's statistically significant. It's a little bit on par, but in Canada, it is quite different. So we do know that Black people have about half the smoking rate compared to white folks. Nonetheless, it's important to understand the intersection between anti-Black racism and smoking, because smoking is associated with stress. And so racism causes stress. And so people have different coping mechanisms. Even though we're seeing in Black communities, smoking is not the number one coping mechanism. When we do have African Americans or Black folks who are smoking, it makes for what I would call a lethal cocktail, because Black people are more likely to die from smoking related diseases because we have higher prevalence of like diabetes and hypertension. So it makes for a really, really terrible combination when we're thinking about mortality. And so we do need to make sure that we understand this issue and have appropriate tools to address it. So with that, I will turn the virtual microphone over to my colleague, Jama.
Thank you, Onye, and thank you for really contextualizing the real root issue of all of this and what we're trying to do moving forward now with me and myself and Brenda. I should go next slide. Is to really contextualize it in the realm of smoking cessation. So, as Onye mentioned, Black populations, Black folks are, twice as likely. Are half as that their smoking prevalence is half of that of white adults. They also smoke fewer cigarettes. Yeah, they're more likely to die from smoking related diseases. And the paradox of that matters. It's really critical to understand that the gap between lower smoking rates and worse health outcomes, and that the gap is not about really individual behavior, and it's about systemic racism and structural inequality shaping health at every level. And again, as Onye mentioned, it's not really unique to Canada, but it's also research shows in the States as well that despite lower cigarette consumption, Black adults have the highest lung cancer incidence and mortality rates compared to other racial and ethnic groups. And when it comes to cessation, the ability to quit, research shows that Black adults are as likely as white adults to attempt quitting, but they're significantly less likely to succeed. So this gap also tells us that there's something critical about it. It's not about motivation nor willpower, but it's about the barriers that exist that are inhibiting folks from achieving that success. So standard smoking cessation programs weren't really designed with Black communities in mind. They don't account for the lived experiences, the cultural context, or the structural barriers that Black adults face, and they're not working. The current system that we have in place is not really working, as we're seeing that folks are not really being able to access such services or being successful in the services that they are accessing. So this is why culturally responsive, community informed models are just not nice to have additions to our smoking cessation landscape, but rather they're imperative and crucial to the success of Black communities. So I'm gonna pass it off. I was just about to set the stage for us, and I pass it right back to Brenda to take it from here.
Okay, hi everyone. Thank you, Jama, as well. So good afternoon. My name is Brenda Osei-Boadi, and I'm a registered social worker and therapist at CAMH, working with UVAST in the Intrepid Lab. So my work involves supporting both youth and families from diverse backgrounds, and including Black youth and adults, using trauma-informed and culturally responsive approaches. So as part of today's session, I'll be bringing a therapeutic lens to smoking and vaping cessation in Black communities, focused on how mental health, stress, and lived experiences influence nicotine use, and how allies, providers, and community members can have supportive, non-judgmental conversations. So just to remind you of the objective here, so by the end of today's session, with my portion at least, the goal is for participants to recognize how mental health stress and intersectionality shape smoking and vaping in Black communities, and to use trauma-informed, culture-responsive communication to support cessation. This is especially important as we go through as we discussed this with important allies and providers, and especially since we're trying to build conversations that is rooted in trust and building rapport. Sometimes you may unintentionally reinforce stigma, disconnection, or dismissal of lived experiences if this is not taken into consideration. Okay, so as my colleagues have already mentioned, while smoking may not be the #1 tool for coping for Black folks, it is still a coping tool that is used. So one of the most important things to understand is that smoking and vaping are often not just habits, they are coping tools. For many Black youth and adults, nicotine may serve as a way to manage chronic stress, anxiety, emotional pain, or feelings of overwhelm. This stress doesn't exist in isolation. It can be connected to experiences of racism, discrimination, microaggressions, financial stress, or feeling unsafe or unseen in certain environments. It is also important to recognize the role of intersectionality, the idea that people hold multiple identities that shape their experiences. For example, a Black youth who is also part of the LGBTQ+ community may face both racism and homophobia. A Black newcomer may be navigating racism alongside immigration stress and cultural adjustment. A Black single parent may be managing racial stress alongside financial pressure and caregiving responsibilities. And these overlapping identities increase exposure to stress, often referred to as minority stress at times, and nicotine may become one of the tools used to cope with that cumulative burden. Specifically for youth, vaping may help them manage academic stress, identity development, discrimination at school, or social pressures. It also is important to acknowledge that for Black youth, particularly Black males, are often adultified. They may be perceived as older, more threatening, or more responsible than they are, and therefore are not always afforded the grace of being seen as children navigating stress. When emotional support is limited and correction replaces care, youth may turn to peer-based coping, including smoking, including vaping. And then for adults, smoking may be tied to long-term stress, workplace discrimination, caregiving responsibilities, or other systemic barriers. Nicotine can be a temporary relief, even though it may create long-term harm. So when we approach cessation, we must understand that we may be asking someone to give up a coping mechanism that has helped them regulate their nervous system and survive difficult experiences. A therapeutic lens encourages us to move from judgment to understanding. The light went out a little bit. I might just stand just to get some. Oh God, it's not gonna work. It's okay. I'll just continue on. Okay, so next, I want to move on to why standard cessation conversations can miss the mark. So, standard cessation conversation often focus mostly on physical health risk of smoking or vaping. While this information is important, it may not address the emotional or social risk of smoking and vaping. So too often Black specific stressors such as racism-related stress, discrimination, community trauma, or mistrust in healthcare systems are not meaningfully explored or integrated into cessation plans. When these realities are minimized or excluded, the plan can feel disconnected from the person's lived experience. Historically, Black communities have experienced trauma, stigma, discrimination, and mistrust of the healthcare system. And because of this, conversations about smoking cessation can sometimes feel targeted, judgmental, and unsafe, particularly when individuals already carry intersecting marginalized identities. So if someone feels judged, stereotyped, dismissed, or misunderstood, they are less likely to engage openly. Instead, a therapeutic approach centers empathy, cultural humility, and curiosity. It recognizes that nicotine use often develops within the context of lived experience, systemic stress, identity, and emotional coping. Our role is not to shame, but to understand, to support, and create space where people feel safe to explore the changes that they're looking to make. So, how do we start the conversation? How we start conversations matter deeply. Instead of telling someone they should quit, we begin first with curiosity-based questions. So for example, what does smoking or vaping do for you? When do you notice the urge the most? What kinds of stress are present in your life right now? These questions communicate respect and openness for Black youth. For Black youth especially, having an adult or provider approach them without judgment can be incredibly impactful. Many youth are used to being corrected, disciplined, or surveilled rather than emotionally supported, particularly Black males who are often viewed through a behavioral lens rather than a developmental one. So approaching them with curiosity instead of correction reinforces that they are young people deserving of care. This approach helps build trust. All right, continue on, avoiding judgment and perceived bias. So it's important to recognize that Black individuals may be especially sensitive to judgment in healthcare spaces, given the historical and ongoing inequities. Even well-intentioned providers or allies can unintentionally come across as blaming or dismissive of someone's unique context. So when racialized stress is minimized, for example, framing stress as purely individual without acknowledging the systemic factors, it can feel invalidating. We can reduce this by normalizing stress, acknowledging systemic realities, and using collaborative language. So again, instead of saying you should quit, we might say, I'm wondering what your relationship with nicotine has been like. And also, we're gonna mention tone. Your tone matters. People are often more open when they don't feel singled out, shamed, or dismissed, when the tone is of warmth and exploration and curiosity. This shifts the conversation from authority to partnership. Another few slides to go. Sorry, actually, there we go. Okay, so trauma-informed communication. So trauma-informed care helps us understand behavior within a context. As Dr. Onye already mentioned, racism is trauma, and a lot of Black people and people of any racialized groups tend to associate their experiences in a trauma-based lens. So instead of asking what is wrong with you, we ask what has happened to you, what has helped you cope so far. For many Black youth and adults, experience of racism, discrimination, exclusion, or intergenerational trauma create chronic stress. Nicotine may be one of the tools they've used to manage stress thus far. Nicotine use is part of a survival story for some, not just a health behavior. So trauma-informed care is grounded in key principles around safety, trustworthiness, and transparency, choice, collaboration, empowerment, and cultural humility and responsiveness. So when we apply these principles into smoking and vaping cessation, we move from control to partnership. For Black youth who may feel surveyed and identified, safety and choice are critical for their ability to be able to foster the changes. Okay, and then for Black adults who may carry mistrust from past healthcare experiences, transparency and collaboration are essential. So I want to repeat that again. For Black adults who may carry mistrust from past healthcare experiences, transparency and collaboration are essential. So recognizing nicotine use within this framework allows us to approach cessation with compassion and dignity. Right, so integrating mental health into cessation. So mental health and nicotine use are deeply connected, as we've already established here. Supporting cessation means also supporting the emotional well-being. This includes exploring stress, anxiety, depression, sleep, social supports that they have or may not have. For Black youth and adults, culturally safe mental health support can play a critical role in reducing reliance on nicotine as a coping tool and helping them to, whether it's to strengthen or find other alternative healthy ways of coping. If we ignore mental health or ignore how racism-related stress affects mental health, we miss the root drivers of nicotine use. When mental health improves, readiness for cessation often increases as well too. Okay, and then to add on to that, we would take a harm reduction approach to engage therapeutically. So not everyone is ready to quit immediately, and that's okay. Harm reduction allows individuals to move at their own pace. This may include reducing use, identifying triggers, or developing alternative coping strategies. It could also just include just creating the space where they can feel safe to learn more about it so that when they are ready at some point in the future, they can reach out and get the support they need, especially when they already have a mistrust in the system. So for Black communities that have historically experienced systemic control and surveillance, again, offering the choice and autonomy is especially important. Harm reduction keeps people engaged instead of pushing them away. It reinforces the dignity and self-determination that we're hoping to help them instill within themselves. Okay, and then lastly, looking at the therapeutic relationship with anything in life, the relationship will always be the thing that remains. As Maya Angelou once put, people may not remember exactly what you said, but they will remember how you made them feel. And that goes a long way when you're trying to build safety and trust and help someone work through changes that have been probably hardened and embedded in them for a very long time. So at the core of cessation support is the relationship. People are more likely to consider change when they feel safe, respected, and understood. For Black youth and adults, feeling culturally understood, emotionally supported, and not stereotyped can significantly impact engagement and outcomes. The relationship is often more powerful than the specific cessation tool. So it always starts and ends with the rapport building that you have with that particular person. Then allies and providers play an important role in creating that space. Okay, so just a few takeaways from my section here. To summarize it, smoking and vaping are often connected to stress, mental health, and lived experiences. Black specific stressors should not be minimized or excluded from cessation planning. Trauma-informed, culturally responsive, and non-judgmental conversations help build a trust, and strong supportive relationships create the foundation for meaningful and sustainable change. So thank you for taking the time to reflect on the therapeutic and mental health dimensions for smoking and vaping cessation in Black communities, especially during Black History Month. This work reminds us of the importance of culturally responsive, compassionate care that honors lived experience, protects dignity, and promotes healing. I'll now pass it over to Jama, who will speak more about the culturally responsive cessation models and programs being developed currently.
Awesome. Thank you, Brenda. So I really wanted to get into, and I know we don't have much time, so I will try to breeze through this as quickly as possible. But really trying to understand why standard programs don't work for Black communities, and it's really because most of the programs that we have available were not designed with either Black communities in mind or working alongside Black communities. It was really designed for the general population, but it really misses out on those who are, very consistently being left and that are falling through the gaps. So really a one-size-fits-all approach so 5 missing elements that we've observed was that a one-size-fits-all approach that ignores the cultural context and lived experiences. There's no one-size-fits-all approaches. The provider gap, so there's staff that are lacking cultural competency or comfort working alongside Black communities. They haven't been trained to recognize racism as a health factor. Another aspect is there's no acknowledgement of racism within the medical training, or within the training in general. So treating anti-Black racism as a backdrop rather than a direct determinant of health outcomes, the absence of community voices, and as mentioned, programs being designed without Black communities involved. They're designed in boardrooms and not really designed in partnership with people from Black communities who will actually use these services and can tell you firsthand what they need and what they're lacking. And then finally, a lack of flexibility. So it's a matter of getting what is available to you and not really tailoring it towards what the needs are of the community. Different communities. One of the biggest issues is the homogenization of Black communities as a whole, and not understanding that different communities have different needs and different concerns, and really trying to internalize that and understand what are the specific needs that Black communities and those specific Black communities have that need to be addressed. And finally, limited cultural tailoring. So systemic reviews show that most cessation research includes very few Black participants, and of those studies that do, fewer than 10% of cessation of developed interventions specifically tailored for Black populations. So this means that most programs are not informed by Black cultural values, communication styles, or specific barriers. So when we ask Black Canadians what they need through the research that we've conducted here at Intrepid Lab, they mention that they need options. We need to be heard. We need programs designed with us, not for us. And that's really where some of the work that we've been developing comes into play. So what we've developed is something that will be, we're still in the process of, rolling this out, but developing a smoking cessation services for Black communities called the Menu of Services. So from our community of research, we really developed this framework to think of it as a very flexible approach to cessation care. And it combines two critical elements, provider education, which includes training healthcare providers to understand anti-Black racism and deliver culturally affirming and responsive care, as well as culturally adapted cessation supports, and that ranges from low to high resource intensity, depending on what people and communities needs. So we have 4 different levels here. We have our behavioral support, we have our behavioral plus digital complement support, we have our community-driven, community-based outreach support, and as well as integrated support as well. So really, as you can see at the bottom here, what we really try to do is ensure that it is flexible, that is adaptable, it is scalable, and it's also evidence-based. So organizations can really start with where they're at, and they can expand as they build capacity. The adaptability piece, so communities can customize which level of combination fits their needs. Scalability, it works across different healthcare settings. So we're thinking about clinics, community organizations, public health units, and not just specialized cessation clinics. And as evidence shows it work, community-based participatory models like CEASE have delivered cessation interventions to over 800 Black participants over a decade, and building sustainable and trusting relationships is really what's most important when delivering such care. When we're thinking about the 5 interdependent pillars, our community research identified these pillars to make culturally responsive design actually work. So these 5 elements need to work together, and if they're missing one, then the intervention truly falls short. So the first pillar that we see is variety and options. So really providing folks with virtual or in-person care, different options of medication versus non-medication options. So when people have choices, they're more likely to engage, and they'll stay engaged because they feel heard and respected. And research confirms this when cessation programs offer contingency management combined with behavioral support, quit rates jump. When programs add flexibility in delivery, allowing people to choose between individual or group counseling, retention and success rates both improve. There's also the aspect of representation, and this is not just simply hiring Black staff so that folks feel like, they're seeing someone of their same communities, but it goes deeper than that. It means having Black providers and leaders in program design and governance, not just as frontline workers and staff who are culturally informed, culturally responsive, and regardless of their own racial background. So non-Black providers who understand anti-Black racism and can commit to humility can also be providing such care. Community advisory boards where people with lived experiences have real decision-making power, diverse representation within subgroups, subprograms, so Black women, folks from the LGBTQI plus communities, and for youth as well, as Brenda mentioned or spoke highly about. The next pillar we have is education. So really having provider education and ensuring healthcare workers have that training on anti-Black racism as a social determinant of health, and really understanding how that impacts the care and the treatment that they will be providing, as well as community-based education. So we need capacity building for communities themselves, right? Education about cessation strategies and options, how to navigate the healthcare systems, mentorship, skill building for peer supporters, public awareness about smoking cessation successes in Black communities, and so on and so forth, so that folks really have that information to really take on their quit journey, and really take ownership of that. The fourth pillar we have is peer and community support, and really just providing accountability partners for one another. One participant shared that relationships are so fundamental to healing and well-being. So if we're talking about smoking cessation specifically, I feel like just having accountability partners, mentors, or other Black people trying to quit, that's critical in my journey. So it really shows the importance of having folks who are alongside you in the journey, but also being able to lean on folks who might have gone through similar journeys as you, and yet you can rely on and you can get tidbits of information from. And then finally, we have incentives, and this can be either gift cards, this can be tokens, this can be, in AA meetings, you get your token that says, hey, you're 3 months quit, you're 6 months quit, whatever it might be. So really just showing that you're working towards something, we're invested in you, we're showing you that, this is something that you're accomplishing, but much like a lot of things that when you're accomplishing, you want to reap the benefits of your efforts that you're putting in. So really, I believe, yes. Okay. So to really tie it all up, I'm going to skip that last slide just because of time. We really need to think about designing alongside communities. When we think about community members, we need to think about for healthcare providers, we need to think about what Black communities are telling you, right? This is, again, not moving away from that homogenized thinking, but thinking about the specific Black communities that you are working alongside and you are serving. What are those specific needs that they have, and how can you address those specific needs for them? And then working alongside them to really figure out what is that next step? What are we planning towards? What are we building towards? For organizations, you need to start where you are. You need to partner alongside Black communities. You need to partner alongside Black organizations, B3 organizations, and really commit towards anti-racist practices. And for communities, it's really about advocating for yourselves, right? Demanding a seat at the table. And a lot of Black communities continuously do that. But all these things don't work without all these three working in tandem. So I leave you all with that. I know we're at about 5 minutes and wanted to offer folks some opportunity to ask any questions. But I want to thank Brenda, I want to thank Onye, and I want to thank Rachel for really putting this all together and ensuring that we're able to speak on this during a critical time as well, and during Black History Month. So thank you all, and thank you all for attending too.
Thank you, all three of you. That was a really great and engaging presentation. And as Jama mentioned, we wanted to leave some time to open it up for questions. If anyone had any, you can put them in the chat right now.
I think somebody had raised their hand. Rosa, I think.
Rosa, did you have a question?
Oh, she said it was by accident.
Oh,
Hi, Rosa. Hi, Rosa.
Hi, Rosa. Oh yeah, there will be a copy of the slides sent out to people who register for this webinar. In case anyone was wondering, I saw that come up. Let me just check if anything was missed. And I'll give everyone just some more time in case anyone does have questions. Okay, well, I have the, yeah, there's a lot of, you can see the chat, but I can tell everyone enjoyed it as much as I did, which is great. And if any questions do come up, our presenters' emails are on the screen. You're welcome to reach out to them as well. But for now, okay, I'll close it off with some final reminders that, again, if you wanted to receive a letter of completion for this great webinar, to make sure that you complete the evaluation and the post-learning assessment, and both of those will be emailed to everyone who registered by tomorrow. And you'll have a week to complete that in order to be emailed your letter of completion. And we have another webinar coming up in March 11th, and it's on guiding change using motivational interviewing to address vaping with Rosa Dragonetti. And registration will be opening for that soon. And we do have an archive list of our previous webinars, and a recording for this webinar will be available as well too. But for now, thank you. That was such a great presentation, and I can tell everyone found it really informative and insightful as well. So thank you, everyone. And thank you, Jama, Onye, and Brenda for joining today.